Now?
Yes, doctor. Maybe we can start
Yeah, I'm
first.
just sharing it. Then I will get the link. I copy it into the chat room. So now,
Yes, doctor.
just a moment.
Maybe we can start.
Yeah, I'm just sharing it. Then I will get the link. I copy it into the chat room. So now,
Yes, doctor.
just a moment.
Maybe we can start.
Yeah, I'm just sharing it. Then I will get the link. I copy it into the chat room. So now,
Yes, doctor.
just a moment.
Maybe we can start.
Yeah, I'm just sharing it. Then I will get the link. I copy it into the chat room. So now,
Yes, doctor.
just a moment.
Maybe we can start.
Yeah, I'm just sharing it. Then I will get the link. I copy it into the. Okay, now we are live on YouTube, and in the chat here I will post the link. You see it here. Now we will start sharing our presentation. Do you see my presentation right now? Arfan?
Yes.
Yeah.
Yes.
Okay. Now we will start sharing the presentation right now. Bismillah ar-Rahman ar-Rahim, dear students. We are going to present to you today part of the glaucoma curriculum, which is the primary angle closure glaucoma. I think if you pay little attention for this lecture, you will get some of the information that we want to pass to you and let you know about the glaucoma. Actually, primary open angle glaucoma, what should you know about? You should know something about the pathogenesis, classification, and whether it's intermittent or acute congestive or post-congestive or chronic. But before this, you have to know how did the aqueous get secreted and drained. Anatomically, the aqueous is secreted by the ciliary body, as you could see here. It is secreted here in the ciliary body processes posteriorly, as you could see here. Then it passes in the posterior chamber between the lens and the posterior surface of the iris and into the anterior chamber. Through the anterior chamber, the aqueous is drained through the conventional route, which is A here, which is the trabecular meshwork, and the uveoscleral outflow, which is B here, and the, to a little extent, iris outflow facilities, as you could see here, but to a little extent. Actually, 80 to 85% go through the conventional route, and uveoscleral outflow is around 15 to 20%, and the iris outflow is close to 5% only. What is the anatomy of the angle? The anatomy of the angle here is we have the Schwalb's line, which is the ends of the Descemet membrane, then the trabecular meshwork, then behind the trabecular meshwork we have a circular channel to collect the aqueous, which is the Schlemm's canal, then the sclera spare and the iris processes, the anterior surface of the ciliary body and the iris root. This is the anatomy of the angle. Here is the trabecular meshwork, this little pink line anterior to the sclera spare and posterior to the Schwalb's line. This is called the trabecular meshwork or the trabeculum, through which the conventional routes of the aqueous goes through. Uh, there are several grading systems for the angle widths, and according to this one, we could call the angle as open or closed. For example, the Schaeffer's grading system, it is grade 4 means that you see four structures, which is the Schwalb's line, trabecular meshwork, scleral sphere, and the root of the iris or the ciliary body. Grade 3, and this angle width is close to 40 degrees, between 35 and 45 degrees. Grade 3, you see only three structures, the three most anterior structure, which is the Schwalb's line, the trabecular meshwork, and the scleral sphere. And the angle width here is between 25 and 35 degrees. Grade 2, which is only the trabeculum is visible in addition to the to the Schwalb's line. Angle closure here is possible, but sometimes it's not unlikely to occur. Grade 1, the angle width is close to 10 degrees, as you could see here. You see that the iris comes very close to the trabecular meshwork to the extent that it occludes most of it. And here only Schwalb's line and perhaps the top of the trabeculum is visible. There is a high risk of angle closure here if the patient is exposed to pupillary mydriasis and the iris get crowded in the angle of the anterior chamber. Especially at dark light in the cinemas, if you are watching TVs at night in a dark room, and if you lean forward with your face down. Grade 0 means iridocorneal touch is present here. The iris is in contact directly with the cornea, and the apex of the corneal wedge is not visible here. You see here that you see still wedge of the beams of light on the anterior and posterior surface of the cornea. Here you could see it, but here there's no wedge of the beams is visible. And sometimes we use indentation gonioscopy to open to see if this an appositional angle closure or cynical angle closure. Okay, how did you see these structures in the angle? We see it by what we call it gonio lens or gonioscope. With this gonio lens, it has a mirror, is a reflecting mirror to look to the opposite direction of the angle. It might be the Goldman one, which is single mirror lens, or a four mirror Zeiss gonio lens to get a quick access to the four quadrants of the angle in one look. So but with this one, which is a little flatter than the Goldman one, I mean that the Zeiss one is a little flatter than the Goldman one. It is used for indentation gonioscopy, and it requires no coupling substance like methyl cellulose. It is not suitable for argo-laser trabeculoplasty, but it is suitable only for indentation gonioscopy, which differentiates between what we call it cynical angle closure. It means adherence of the iris to the angle structure, and oppositional, I mean that forward movement of the iris because it's overcrowded, it is crowded in the angle of the anterior chamber. As you could see here, here's the angle, and this is the different grades. Here's the angle is closed, and if we did indentation, we pressed on the dome of the lens with the gonio lens here, the fluid is pushed to the periphery and it pushes the iris backward and it opens the angles again. Aqueous is forced into the periphery of the anterior chamber to see, and this means that it is a positional angle closure and not cynical one. Indentation gonioscopy, as you could see here, and you see a little iris processes attached to the trabecular meshwork here. Here we have a complete angle closure. The apex of the corneal wedge is not visible. This is before indentation. After indentation, you see that parts of the angle is forced to open and the parts of the angle remains closed with BAS is peripheral anterosynechiae. This is the iris processes attached to the trabecular meshwork. Okay. What is the predisposing factors for uh, angle closure glaucomas? Number one, small, short eyes, especially present in Southeast Asians and Chinese and Thais people and some people like this. And convex iris lens diaphragm. I mean that all the structure is convex anteriorly in shallow anterior chambers, especially in hypermetropes, and narrow entrance to the angle structures. Okay. Uh, how did pupillary block occur? If pupillary block is increased in the physiological pupillary block in cases of sequence, crowded anterior segment structures, the aqueous is trapped behind the iris and pushes the iris forward because it's the uh, physiologic pupillary block here, and the iris is pushed anteriorly, and then it occludes the entrance to the angle, obstructing the way of the aqueous and the peripheral iris into the anterior chamber angle and consequent rise on the in the intraocular pressure. Okay. Here we have either latent, asymptomatic, subacute, acute, or chronic, or absolute glaucoma. This is the classification of primary angle closure glaucomas. Latent primary open angle glaucoma is usually asymptomatic. No symptoms is present. Intraocular pressure might remain normal, may progress to subacute or acute and chronic. Subacute one, it is a form of latent or intermittent angle closure, which occurs usually at nights, and the patient is coming to you complaining of when I am watching TV at night, I usually get to see a glare around the lamps, halos around the light. Then, after a while, with little headache and little decrease in the in the visual acuity, but later on it breaks down and the attack is released again when the pupil get constricted and he opens the light. But this subacute stage could develop acute angle closure and get an acute attack which you will not break except if the doctor interfere either medically or surgically, or might go and creep little bit to the chronic angle closure, similar to uh, the angle, the primary open angle closure one. Acute primary open angle glaucoma is a congestive type of glaucomas. This is a sudden total angle closure with sharp rise in the intraocular pressure, and it might go to post-congestive and follows acute attack. Chronic angle closure or creeping or latent angle closure follows intermittent attacks or is a subsequence of the acute angle closure. Absolute glaucomas, when this cases is badly managed or not appropriately treated, it will pass to absolute angle closure glaucomas, which is a blind, painful eye, no BL, no perception of light, follows repeated attacks of angle closure with subsequent damage in the optic nerve, head, and retina, fibrillary, and ganglion cells, and the patient gradually lose vision. And this is one of the most difficult cases in glaucoma. If you want to see the intermittent angle closure glaucomas, what are the symptoms? What are the signs? And how are you going to treat? Simply, intermittent angle closure. That means there is on-off angle closure. On means that the angle is closed or occludable, especially if you have a precipitating factor. The precipitating factor is dark room, watching films in cinemas in a dark room for a long time, leaning forward with face down. So you push the iris lens diaphragm forward. With this increase this angle closure, followed by rise in the intraocular pressure. Fluid is pushed into the cornea, leading to corneal edema, epithelial edema, after closure of the angle. This epithelial edema is the source of halos around light. Okay, this attack could break down by itself, or it needs treatment. It might break out by itself when you change situation. I mean that you get out into the open light. So with the stimulation of light, the pupil get constricted. It withdraws the angle, the iris from the angle of the anterior chamber, opens the angle, and the aqueous is drained through the angle of the anterior chamber, and intraocular pressure is decreased. Or you are going to break the attack by giving a myotic eye drops like pilocarpine and treat it with bilateral YAG laser iridotomy, as you see here, to create another pathway for the aqueous from the posterior chamber to the anterior chamber, so it didn't allow for aqueous to accumulate behind the iris and push it forward. Okay, if we have acute congestive angle closure, or if this intermittent attack is repeated and we didn't get to do some of the prophylactic measures like use of pilocarpine or myotics or doing a peripheral iridotomy, acute congestive angle closure glaucoma develops with sudden pain, the sudden diminution of vision after following glare around the light because of severe corneal edema, and the patient has severe headache, sudden decrease in the intraocular pressure, and the eye is congested, pain, and sometimes vomiting. And if you see this patient and you examine him, there's so many components: severe corneal edema, dilated, vertically oval, mid-dilated pupil. It is not reactive to light because of the ischemic behavior in the iris muscles. And we have ciliary congestion because of the increase in the intraocular pressure, and the anterior chamber is shallow, as you could see here. And if you did gonioscopy, you see complete angle closure. I mean that the iris is very close to the cornea, and it is Schaeffer's grade 0, as I told you earlier, and they have 4 main structures in the angle. You don't see any of the structures in the angle. You just see the cornea and the iris and nothing in between. Okay? Okay, how are you going to treat such a case, which is acute emergency? Either if you are an ophthalmologist or you are a general practitioner or a house physician sitting very far peripheral in the rural area, you should be able to identify such a cases, because it is crucial to not to mess it up. And it is one of the most important differential diagnosis in ophthalmology, which is painful red eye. I mean, painful red eye, which might be acute angle closure, acute corneal ulcer, or conjunctivitis, or iritis. The treatment strategies is different in such a cases. If you have a painful red eye and you diagnose it as iritis, you are going to give mydriatics. But if it was acute congestive glaucoma and you mistaken this one and you give mydriatic because you misdiagnose it as corneal ulcer or misdiagnose it as iritis, you will give Mediatic. It will worsen the case more and increase the angle block and increase the intraocular pressure, and you are going to mess the case up. But if you was able to identify it, you will start to give it a high ocular hypotensive agent, both systematic and topical. Uh, the lines of treatment here, you are going to give something systematic like acetazolamide 500 milligrams intravenous if it is available. It will decrease the intraocular pressure sharply by decreasing the release of aqueous in the ciliary body. So aqueous production is inhibited through the carbonic anhydrase enzyme inhibition, and its action starts within 15 to 30 minutes. And then you maintain it with oral carbonic anhydrase inhibitors as well, like Sedamex. Also, you could give a hyperosmotic agent if it is appropriate, like glycerol, which is to be ingested with juice or lemon juice or orange juice, because it is to make it palatable. Or you give intravenous mannitol to decrease the size of the aqueous, the vitreous here. But the dose here is very important. Intravenous mannitol, 2 grams per kilograms of 20% solution within half an hour. Otherwise, it is not working well. Glycerol, you get 1 to 1.5 gram per kilogram of 50% solution. This is what we call it hyperosmotic agents. This is the systemic treatment. And then we'll give the topical therapy like pilocarpine. You should think systematically to withdraw the iris from the angle, to decrease the aqueous production and increase the aqueous outflow. How are you going to increase the drainage of the aqueous through the angle? By withdrawing the iris from the angle, and so it make it more wide and allow for the aqueous to pass. And also, because of contraction of the longitudinal muscles of the longitudinal portion of the ciliary muscle and contraction of the ciliary muscles, which is attached to the scleral spur, it will pull on the ciliary, in the scleral spur, and open the trabecular meshwork. This facilitates the aqueous outflow. So it increases the aqueous drainage by withdrawing the iris from the periphery, and it will facilitate the aqueous outflow by reopening the trabecular meshwork or the trabeculum by pulling on the scleral spur through the longitudinal portion of the ciliary muscle. To give beta blockers like timolol, betaxolol, something like this, and these are very important drug to give because it inhibit the release of aqueous at the ciliary body. In addition, to give topical carbonic anhydrase inhibitors, but if you are giving systematic carbonic anhydrase inhibitors, no need to give topical one, because it add nothing to the medication armamentarium. And also with this case, there is a little inflammation because the eye is angry, you give topical steroids. If the attack is broken, you should do something to prevent repetition of the attack, both in the same eye and in the fellow eye, which should be predisposed to the same situation. To both eyes, you have to do YAG laser peripheral iridotomy. Okay, if the attack was not broken, this patient should be subjected to surgical peripheral iridectomy because of invisible iris, so laser will not work, or to do conventional trabeculectomy or something like posterior scleral tap to withdraw something of the vitreous, which is very advanced for you. This is simply the treatment of acute attack of angle closure glaucoma. Here, it is very important to remember that it is completely prohibited to give mydriatic, especially cycloplegic agent like like atropine, cyclopentolate, and medricial. Okay, in the post-congestive angle closure, if you are seeing a patient with faults on the distal membrane here, and there is a rise in the intraocular pressure and the stromal iris atrophy because of repeated attack of angle closure and the inflammatory process accompanying this situation, and the posterior synechiae, I mean that the posterior surface of the iris is attached to the anterior surface of the lens, and you see fine pigment on the iris and some pigments on the, as you could see here, there's some pigments on the anterior surface of the lens and on the back of the cornea because of the accompanying iritis. So angle closure is not only mechanical angle closure, but it is angle closure in addition to inflammatory process, which make it worse. With disturbances in the intraocular pressure and accompanying iritis, we have some disturbance in the metabolism of the anterior chamber with consequent development of anterior subcapsular opacification here in the pupillary area. We call it glaucomoflecken, and also with repeated attack of angle closure and repeated attacks of ischemia, there is damage to the dilator and constrictor pupillae muscles, and you see a dilated fixed pupil. Dilated fixed pupil. So these are the signs of post-congestive angle closure glaucoma, and it is treated accordingly. If the end here, there's no place for laser peripheral iridotomy because sure the angle we do laser peripheral iridotomy if we think that the angle is still healthy and it can drain the aqueous outside the eye. But if it is not like this, we have to create another channel for the aqueous outside the eye through trabeculectomy or valves or something like this. If this attack was not so much acute, but it was intermittent angle closure, creeping angle closure, it will pass into what we call it chronic angle closure glaucoma, which is close or similar to the primary angle closure glaucoma, with the consequent cupping of the optic nerve head and the loss of the neuroretinal rim areas and the visual field loss. If you did gonioscopy in such a cases, it is easily missed cases, except if you do gonioscopy. If you do gonioscopy, you will find the synechial angle closure to a variable extent. Okay? These are the most important parts of the angle closure glaucoma. The only part that you should know is if you have a case of absolute glaucoma, I mean that absolute glaucoma that is painful blind eye following repeated attack or acute attack of angle closure. I mean that the eye is painful, red, with no perception of light. It is usually treated by denervation of the eye to keep it away from pain only, but no way to have vision restored again in such cases. Did anyone need to know something about the any question here? Are there any question here? Dear students, Erfan,
Yes,
yeah, no one is raising his hand. I see nothing. Nobody is raising his hand now. This means that they are sleepy
there
or
are some,
it's
maybe someone.
Is there some here?
Someone. Yes.
Okay, who you could open the who is raising his hand? No, no one is raising his hand now. If anyone want to ask any question, he should raise his hand and uh, uh, open the mic for him to talk. Irfan?
Yes, doctor.
Yeah. No question.
Maybe no question, doctor.
Maybe no question. You don't need to know any question now.
Hmm.
And you as well.
Yes.
Okay. Now it is not that big lecture. It is all what I presented is on YouTube, and I shared to you. You could go the link back, and I will reshare it again here. Okay, you could get it recorded on YouTube, download it, and listen to it. It is. I hope that it is beneficial for all of you. Okay.
Okay, doctor.
If you need anything in the topic in glaucoma or any part of ophthalmology, I am ready to help all of you if you need, and we could present anything on Zoom through the same channel with the same username and password, and it is the same meeting ID. It is available all the time. If you want to review anything in ophthalmology, I am ready to help all of you. It's okay.
Yes.
Okay, we could share anytime. Just send me. I will help all of you, and I will give you my.
There is someone raising his hand.
Okay,
Sabri.
open the mic for him. Hmm?
Hi, doctor.
Hi.
Actually, I don't have a question about the glaucoma. I have a question about chalazion.
Lesion. Yeah. Okay.
Which one is occur first between a hordeolum internum and a chalazion?
Lesion is an inflammation and cystic, chronic or acute inflammation, which occurs by obstruction of the meibomian gland. If it gets obstructed, and the meibomian secretion is trapped inside the meibomian gland, it will invoke a kind of inflammatory reaction about it with swelling. But if you have something like hordeolum internum, it is something acute inflammation with some bacterial infection, something like this.
It could be possible that the complication of hordeolum of the chalazion to be hordeolum internum.
Of course, it could, because if you saw the fate of the chalazion, either it resolved by itself and it completely disappear, or progress to infection, because actually it is not infected that much, it's chronic, but or it is get insisted and pain stops and redness disappear, but only you have a swelling. It's okay. Or open by itself after changing into what we call it micro abscess.
Okay.
And in this case, it is hordeolum internum.
Okay.
Okay. If it is the inflammatory process goes, it will be converted from chalazion into abscess.
Okay.
Use. Okay.
Yes. But if after the hordeolum internum, it could be chalazion?
No.
Why?
Because actually, if you it is chalazion occurs if It is obstructed, and there is no such acute bacterial infection here.
Okay.
But if you develop bacterial infection, it is a complication of chalazion.
Oh. Okay.
You know, it is non-resolved chalazion, which progressed, and the patient didn't get the appropriate treatment on time.
Okay.
Hmm?
Okay. Thank you for your explanation.
You're welcome, Muhammad Sabri.
Yes.
Muhammad Sabri. Okay, you're welcome.
Thank you.
Okay. Erfan,
Yes, doctor.
anyone else? No one yet. Okay. Good luck with your subsequent lectures and your career, and enjoying your life. Study hard and keep away and safe during this era of Corona, which didn't allow us to meet in person in live lectures in the university. It's okay?
Okay, doctor.
Okay. Goodbye.
Thank you, doctor.
Bye. Assalamu alaikum.
Thank you, doctor.
Thank you. Goodbye.
Thank you, doctor. Thank you. Bye bye.
Assalamu alaikum.
Assalamualaikum.
Waalaikumsalam.
Gak terdengar.